Good day and welcome to the Chronic GVHD and Steroids Let's Explore the Love, Hate, and Other Options conference call. Today's conference is being recorded. At this time, I would like to turn the conference over to Jennifer Gillette. Please go ahead.
Thanks, Todd. Yes, this is Jennifer Gillette. I'm the staff social worker at the National Bone Marrow Transplant LINK, and I'd like to welcome you all on the call today. This month's program will focus on the love-hate relationship with steroids while treating GVHD. A special thank you to our sponsors for today's program, the Leukemia and Lymphoma Society, Insight Corporation, Pharmacyclics and Janssen, and Omeros Corporation. We also thank our esteemed LINK partners. Just so everyone knows how our call is going to go today, we're going to have just a few minutes of introduction about the LINK, and then I will introduce our professional speaker, Dr. Masumi Ueda Oshima, and she'll talk for about 20 minutes on our subject. And then we have a survivor with us, Sharde Fultz, and then we'll open the floor for pre-submitted questions and live questions. So for those who may not be familiar with the LINK, our mission is dedicated to helping individuals and their families from diagnosis through survivorship. We provide resources, support, and education. Some of the resources we provide to help families navigate this journey are our webinars, podcasts, blogs, lunch and learn calls for a variety of topics such as chronic graft versus host disease, disease-specific information, caregiving, coping, treatment options, and survivorship after a transplant. We have an active Facebook page with daily inspiration and relevant tips for survivorship. We have our peer support mentor program for patients, caregivers, and donors, our Second Birthdays Recognition program. We also have some wonderful books, and we provide referrals and emotional support from a licensed social worker. So if you feel like you could use some extra support, we encourage you to reach out to us today. Before we begin today's program, I would like to review just a couple housekeeping items. One, everyone can expect to receive a survey from us today. This is to help us keep improving our programming for you, as well as to give us planning ideas. We want to know what you want to hear more about, so that is your opportunity for your voice to be heard. Please also be mindful when we are asking questions today, trying to be as concise as possible so as many people can ask questions as possible. And also know that the information provided in this program is meant to stimulate conversation with your own healthcare provider and is not meant to replace your individualized medical plan. So now on to the educational part of our program. We are so very thankful to have our first speaker with us here today, Dr. Masumi Ueda Oshima. She is a physician specializing in blood and marrow transplantation at the Seattle Cancer Care Alliance and the University of Washington Medical Center. Her research focuses on finding better ways to prevent and treat acute and chronic graft versus host disease. She sees patients in the long-term follow-up clinic as well as in the allogeneic transplant clinic at the Seattle Cancer Care Alliance. She is an assistant professor at Fred Hutchinson Cancer Research Center and University of Washington School of Medicine. She also serves as an assistant medical director for the Inpatient Blood and Marrow Transplant Service. Without further ado, thank you so much for being here with us today.
Yeah, thank you very much, Jennifer. Good afternoon, everyone, and thank you for taking the time to call in today. My goal today is to have a focused discussion and dialogue about steroids in chronic GVHD treatment. First, I'll give a brief background of why and how we use steroids for chronic GVHD. Secondly, I'll go over the main side effects of steroids, which many of you are likely familiar with, but more importantly, focus on what we can do to mitigate or lessen the side effects. At the end, I'll summarize what the field is doing to try to reduce steroid burden in patients living with chronic GVHD. I think it's a really promising time in the treatment of chronic GVHD. There's actually been one newly FDA-approved drug in the last week. And the first FDA-approved drug, ibrutinib, was approved just a few years ago. And soon there will likely be another one approved. So the research in the field is very active, and I think there's a lot of reason to have hope in this disease. So first I'll provide the context of our discussion by talking about the track record of steroids and why we use it and how we use it for chronic GVHD. Actually, we've been using steroids for quite some time. The first study that actually showed effectiveness of steroids for treating GVHD was published back in 1988. So for over 3 decades, steroids has been the first-line therapy for chronic GVHD. And unfortunately, nothing has really been proven to be better or superior to steroids since that time for initial treatment. So the current treatment backbone really relies and continues to rely on steroids as the main treatment. So how do steroids work? Steroids are a very broad-acting medication that inhibits multiple types of immune cells, and its broad activity is why it is quite effective in quickly dampening the inflammatory response in conditions like GVHD. And this broad action is also why there's a lot of the unwanted side effects from steroids, as we'll discuss later on. And in contrast, some of the newer drugs that I'll talk about towards the end are more targeted or specific in that they target specific proteins inside a cell or a particular type of immune cell, and therefore the side effects are less. How well do steroids work? Because of its broad activity, they're quite effective in quickly stopping the inflammatory process and to stop further damage from happening and to avoid the long-term inflammation that can lead to downstream effects like scarring and fibrosis in this disease. And although it works quickly and works well to calm down the acute inflammation, of course, to see resolution of this complex process of chronic GVHD takes time, and steroids serve as a backbone for treatment for that duration. And unfortunately, even though steroids are initially effective, many patients also require a second line of treatment in addition to the steroids, either because of worsening symptoms or progression in other sites or organs, or not being able to successfully taper or tolerate the steroid treatment. How do we, in practice, use steroids? Usually, the guiding principle is always that we use the lowest amount possible and to try to get people off of it quickly and as safely as possible. For newly diagnosed chronic GVHD that requires systemic treatment, we usually start with a dose that's 0.5 milligrams per kilogram to 1 milligram per kilogram per day. So for instance, for an 80-kilogram person, that would be about 40 milligrams a day for half mg per kg. And we usually continue this higher dose for 2 to 3 weeks until we see some response in the symptoms or at least stability, followed by a long taper to get to gradually a dose of the original dose every other day. So, for instance, 40 milligrams every other day over 4 to 8 weeks. And this alternate day dosing really helps with recovery of the adrenal glands, which is the body's normal mechanism for making steroids that we need for daily life. And depending on the particular patient, we may also add a second agent like sirolimus, for instance, up front, but not always. And the approach is that we're always closely following patients, and we recalibrate the treatment and the dose of steroids very carefully to prevent over-treating as well as under-treating someone. And I would say that tapering of steroids is highly variable and it's highly individualized. But in general, we taper the steroids about by about 20 to 30% of the dose every 2 weeks. And the lower we get into the dose, the smaller the increments are for the decrease. And I think much of it is really a trial and error process, and the needed intensity of the treatment really can only be determined most of the times by slowly and very carefully decreasing the dose with close observation and follow-up with your medical team. So now I'd like to talk about the side effects of steroids. Even though it's an effective medication, prednisone is, as you all know, a really, really difficult medication to be on. And actually, there have been studies that have tied steroid use to, lower quality of life. So the side effect profile of steroids really contributes to a person's symptom burden and really impacts their quality of life. So I'd like to focus mostly on how we can try to mitigate the side effects of steroids, and I think the more you know about the side effects, the more power you have to work with your medical team and try to lessen the side effects where possible. First, I'll quickly summarize the major side effects in broad categories. So for skin and things that have to do with one's appearance, steroids cause skin thinning and easy bruising. It can cause weight gain, cushingoid appearance, which is where the fat is redistributed so that it reaccumulates in the face and back of the neck. There's also facial swelling associated with steroid use and stretch marks, what we call striae. For effects on the eyes, we often see cataract and glaucoma disease, in addition to bulging of the eyes with chronic steroid use. In regards to things related to heart health, high blood pressure, and early plaque buildup in the arteries is common, as well as high cholesterol levels, fluid retention, and sometimes even heart rhythm issues. In terms of GI system, steroids can cause gastritis or inflammation in the stomach lining and ulcer disease. Bone health is also impacted by steroids, so osteoporosis and a process that we call AVN, or avascular necrosis, which is where the blood supply to the bone is affected and the bone tissue can die and collapse. It can be a really problematic complication. Myopathy or weakening of the muscles related to steroids is also seen after prolonged use. And then there are the neuropsychiatric types of side effects like depression, mood lability, insomnia, psychosis, mania related to steroid use. And then very commonly high blood sugars or steroid-induced diabetes, and then adrenal insufficiency. So what I touched on earlier with adrenal glands not making enough steroids with prolonged steroid use. And then finally, infection risk is increased related to steroid use as well. For most of the side effects of steroids, the good news is that the effects are reversible with time. So if you're able to come off of steroids or be on a very low dose, most of the effects of steroids will get better with time. There are things that are potentially irreversible, things like effects on the vision because of cataracts or fractures related to bone density loss. So these are things where prevention is really important. So a big question really is, how can we try to mitigate or lessen the side effects? And really prevention and vigilance, I think, is key. Although I think at the same time we have to acknowledge that even if we try everything or do everything right, there are still things that we sometimes can't prevent. But I think that there is a lot that we can do to try to battle the side effects. So the big first category is bone health. So osteoporosis or loss of the density of the bone, and the avascular necrosis is a common side effects of steroids. And actually it's quite common after allogeneic or autologous transplant. It's estimated that about 50 to 75% of all patients have loss in the bone density. And this can be related to prior treatment as well. So we know that chemotherapy and radiation exposure can reduce your ability to make hormones like estrogen and testosterone that are important for maintaining bone health. So in addition to steroids, your prior treatment may also impact your health of the bones. I think the most basic intervention we can employ is to make sure that the intake of calcium and vitamin D are adequate to maintain bone health. So for calcium, we usually recommend a dose of about 1,200 milligrams a day, and for vitamin D, 1,000 to 2,000 international units per day, depending on your dietary intake, to try to delay the development of osteoporosis during steroid treatment. And it's also important to make sure that the vitamin D levels are checked to make sure that you're achieving adequate levels. In addition to that, good diet with protein intake is important. Maintaining an ideal body weight is important. And of course, smoking cessation and limiting alcohol intake can optimize the bone health. And then regular weight-bearing exercise is strongly recommended. There are studies that have shown that exercises like walking, low-resistance weight training, other types of resistance exercises can modestly increase the mineral density of the bones. So participating in regular exercise is crucial. And another thing that we don't often talk about is trying to prevent falls. So we know that if you have low bone density and have a traumatic fall, that the likelihood of fracture is quite high. So one thing we can do to prevent is to help prevent falls by training. And if it's available to you, I think a personalized physical therapist or a trainer can really help with things like improving your balance and your agility, your posture, all of which may reduce the risk of falls and fractures. And all of these things should be done side by side with close monitoring. So we monitor the health of your bones by what's called a DEXA scan or a bone density scan, and it's routine to obtain one at about 3 months after a transplant, and also at 1 year post-transplant, and thereafter, depending on the findings, maybe every 1 to 2 years. The bone density scan will let us know your risk for developing a fracture, and depending on that number, we would recommend treatment with a class of medications called bisphosphonates that can strengthen the bones and hopefully prevent fractures. So there's a lot that can be done to prevent and lessen the side effects of steroids on the bones. Along the same lines, I think close monitoring and early treatment for things like diabetes, high blood pressures, high cholesterol levels can really help to avoid the downstream consequences of conditions related to steroids. This means having regular checks of your blood pressure and cholesterol profile, and screening for diabetes, and treating it early if needed. And this will help to stave off the downstream things like heart attacks and strokes. And on top of that, regular cardiovascular exercise is really important. I think it's hard to exercise every day, but trying to work your way up to even 10 to 20 minutes a day would really make a difference in your cardiovascular health. And of course, all of these things are things that everybody should be doing, not just after a transplant. But I think vigilant monitoring is even more important when you have steroids on board. And I would stress that partnering with your primary care provider, either a family doctor or internist, is really important because they are really the experts in prevention of these complications and diseases. And I think it's a huge help for transplant physicians to have a good primary care doctor taking care of these things. The next common problem with steroids is cataracts and glaucoma, so the eye effects. And for that, I would just recommend that you have your eyes examined at least once a year, if not more often, by an ophthalmologist or optometrist, really to promote early detection of these complications and be treated so that we can avoid effects on the vision. Finally, we know that infection is of higher risk in patients on steroids after transplant. And so in addition to getting the routine post-transplant vaccines, there are also routine preventative medications like antiviral medication, antifungal, antibacterial medications that one should be on while being treated for chronic GVHD. So in the last few minutes, I'll discuss some ways that we are looking at or how we can use other medications to try to reduce steroid exposure over time. This is what we call steroid-sparing agents. So we often will add on another medication that suppresses the immune system in a slightly different way to hopefully lessen a person's overall exposure to steroids over time. And many drugs have been explored for this purpose, including things like sirolimus, rituximab, imatinib, IL-2, methotrexate, and also non-drug therapies like ECP or extracorporeal photopheresis. And right now it's really unknown which secondary treatment for chronic GVHD is really best. And no clinical trial have really compared these different options. So the choice of treatment when we're thinking about starting a steroid-sparing agent is really patient-specific and individualized. And we always considered one's comorbidities or history of other diseases or infection and toxicities and patient preference to try to come up with the best option. And clinical trials are always always a good option if it's available to you. I think it's, as I said, it's an exciting time. There are many trials available for chronic GVHD, and one might be a good fit for you. In terms of newer drugs that we are exploring or have explored for GVHD, ibrutinib is one that was the first drug to be approved by the FDA specifically for chronic GVHD, and it was approved back in 2017. This drug is a BTK inhibitor, so it acts on a protein inside the immune cells that we call B cells. The trial that led to its approval showed very good response rates, up to 70% in patients who previously had progressed on a number of lines of treatment. And they also showed that patients were able to reduce their steroid dose by about half in most instances. Some of the side effects of ibrutinib include things like easy bruising and bleeding, fatigue, diarrhea, muscle spasms. But it's an oral medication that can be taken daily, and it can be effective for reducing the steroid burden. The next drug is called Jakafi or ruxolitinib. This is a JAK1 and 2 inhibitor. It's also a medication that's targeted to a specific protein. And it's actually approved already for acute GVHD, not yet approved for chronic, although a large trial was just completed, and I think that this medication is likely to be approved by the FDA soon. But this medication is a strong anti-inflammatory drug, and in the trial that was recently presented, it did show that most patients did have a response in their symptoms and the severity of their GVHD. And it's a relatively easier medication to take in that it doesn't have a lot of side effects. The main side effect of Jakafi is low blood count, so that is something that has to be monitored while you're on the medication, and sometimes the dose will be adjusted. And then finally, the newest drug to be FDA approved for chronic GVHD is called Rezurock. Actually, it's previously called KD025. But this is a medication that inhibits the ROCK2 protein, which is involved in inflammatory as well as fibrotic pathways. And this is a really unique drug in that it addresses both inflammation as well as the scarring and the fibrotic process of chronic GVHD. In the trial that was completed, they showed that patients, even who had progressed on treatment with ruxolitinib or ibrutinib, had significant response to this medication. And I think the most exciting part was that even patients who had some scarring manifestation or the fibrosis of chronic GVHD in the lungs or the joints in the eyes had response to this medication. Although the responses did take some time, up to 20 to 24 weeks of treatment. About 20% of patients were able to discontinue steroids altogether, and most patients were able to reduce their overall steroid dose. So I think this is an exciting new approval and one that we hope will reduce patients' exposure to steroids. Just to summarize, I think steroids are, at this point, remains a necessary evil in the management of chronic GVHD, and we're always striving to use the lowest effective dose possible. The unwanted side effects are generally reversible, and I think prevention is really the key to mitigating the side effects. And I'll close by saying that it's really an exciting time in the field where we have many new agents and drugs being investigated, and one newly FDA-approved drug available. So I think it's an exciting time in the field, and I think we have reason to be optimistic and hope for a day where we can rely less and less on steroids to manage this disease. So with that, I will turn it over to Sharde.
And I will just comment for one moment because I want to make sure I introduce her, but I also want to thank you so much, Doctor, for sharing all of this. This is so hot off the press with this new drug, and we really appreciate you providing hope as well as all the education you gave today. But yes, now our second speaker is Sharde Fultz. Sharde was diagnosed with non-Hodgkin's lymphoma in 2009 at the age of 21. After a rigorous and often complicated cancer journey that included chemotherapy, radiation, and ultimately an allogeneic bone marrow transplant, she is now thriving despite a diagnosis of chronic graft-versus-host disease. Today, she is a student at Wayne State University and a conference director for a nonprofit that serves young adults with chronic illness. In her spare time, she enjoys all things, as she says, artsy-fartsy, and every chance she has to advocate for young adult cancer awareness. Her favorite quote is Socrates, "A life unexamined is a life unlived." Thank you so much for being with us today, Sharde.
Hi, thank you so much for having me. It's a pleasure. Oh, pardon me. And hi to everyone tuning in. And I'll give you a heads up, I do have a chronic cough, so that will inevitably continue to happen. So thank you for bearing with me. And I'd also like to thank the doctor for just such a frank explanation of steroids and the future of steroids it was really surreal hearing the doctor speak so frankly about them and to get all this information in one chunk because I think usually when we're in the thick of it, it's, you're just trying to survive. So the doctor says, take this, and you're like, all right, thanks. So this was extremely informative. So many thanks to the doctor. I think I'll start with just a little information about my experience with steroids. I've been on steroids for about 10 years now for, a plethora of reasons. As our doctor was speaking, I felt like, oh, my gosh, I'm a textbook steroid gal over here. But early in my cancer diagnosis, they found a mass on my chest that was about the size of a small watermelon, and it was pressing into my lungs. So it caused quite a few lung issues. My lungs collapsed a couple times. I had to get a procedure called pleurodesis, which they kind of virtually glued my lungs back to my rib cage. So that's one of the reasons I need steroids. But also, after my bone marrow transplant, I ended up having an emergency surgery, which left me with an ileostomy, which comes with some gut issues. So another reason for steroids. And then after my bone marrow transplant, I also, as mentioned, ended up with chronic graft versus host disease. So needless to say, thank God for steroids because a sister really needs them, right? And with the symptoms from GVHD, there are skin issues, mouth issues, eye issues. It affects virtually my whole body. So I definitely notice right away if I miss a dosage of my steroid for that week. I am on an every other day prescription, so if I miss a day or two, I really feel it. So, that's one of the ways it affects me. Early on, my symptoms were very textbook. I had the weight gain, the puffy face, which there is apparently a clinical term for it that I wasn't aware of. But I certainly had that. I had really bad acne breakouts out of nowhere, increased appetite. I mean, I was insatiable. I wanted to eat everything. And later I found out I was moody and irritable. I hardly remember because everything was a flash, but I promise y'all my family does not hesitate to remind me. There were, they said I had moments where it was like I was just in a rage and lashing out, which is contrary to my typical nature, I promise you. So it was definitely the steroids right there. And I think emotionally, the way it occurred, speaking of the fact that I don't remember it, I think there's something about the nature of it where, especially when you're going through something like a cancer diagnosis, that you're almost unaware that this medication is having an effect on you. And so I think I assumed that, pardon me, a lot of what I was experiencing, by and large, was just due to having so much going on in my life and, so many health issues and concerns. But in retrospect, especially having to really think about it and kind of write it all out, it's like, oh, my gosh, that was the steroids. Who'd have thunk? But also I want to mention that as the doctor noted, all those side effects didn't last chronically, even though I am on steroids. I've been on them for about 10 years now. I'm no longer experiencing weight gain. I actually had some weight loss, which who knows how many things might have affected that, but that isn't an issue anymore. Sometimes if there are changes in my medication, I still get the puffy face, but not so much the acne or increased appetite. And I like to believe I'm less moody now. I'm definitely not raging and lashing out as I was early on when I first started the steroid. Long term, however, I do have to mention that I have been recently diagnosed as pre-diabetic, which my doctors did forewarn me about, that, it could come with the process. and that's definitely been an interesting experience with the fact that being diabetic due to steroids versus, the more common or natural, I'm sorry, things are going on outside. I don't know if you can hear that, but versus the other reasons that one may become diabetic is that steroids effects on your blood sugar are much more sporadic. So with type 2 diabetes, it's not as easy to just moderate with nutrition. So my doctors currently are looking into medication to help sort of balance that out for me. That's just my story. It's still kind of new, so I'm no pro on steroids effects to diabetes, but just to speak to that is definitely a concern with long-term side effects. And with consideration to that, I think, as was noted earlier, my personal concerns with being on steroids for so long are the effects that it can have on my organs, my kidney health, my bone density, as noted, has been a concern, and as well as my dental health. And thankfully, my doctors have done a good job of keeping these concerns in conversation and things that we can do to try to mitigate, the possibility of these issues arising for me, or, preventative measures and things of that nature. Thankfully, my bone density health is good right now. My nutritionist, she lends that to the fact that I danced for 15 years. I'm a classically trained dancer. And so she said my bones are just packed on some of those nutrients that is needed for now. So if I can recommend anything, put your kids in dance or sports, pack in that good bone health, because it's helping me out now. But with all that said, I do want to mention what I like and appreciate about steroids, and I think it's almost like contradictory, because I feel I feel stronger. My body has been through so much. My lungs have been through so much, and I overall don't feel, of course, as strong as I was pre-cancer. However, in consideration of that, I can't imagine how I would be feeling if I wasn't on steroids. You know what I mean? Because I am aware enough to know that they are contributing to my quality of life. The reason I say it's a little contradictory is because, as our lovely doctor mentioned, that, and I keep saying doctor because I don't want to ruin her name, y'all, respectfully, but as she mentioned, a side effect is weakness, is muscle weakness, and I have experienced that. However, I think the good outweighs the bad. The quality of my life, and oh my gosh, the amount that it relieves my symptoms of the chronic GVHD is worthwhile. So overall, I believe they certainly come with trade-offs, and it's not, how can I put it? It's not obviously like, well, I mean, in some ways it's a luxury because there are people who don't have access to steroids, but, it's not a luxurious experience when you think about all the side effects. And I do believe, the list of the cons, it might be longer than the list of the pros. However, the quality of the pros, the fact that I am able to do more, the fact that it's affecting the inflammation in my body, and the fact that there are resources and advancements along the way. At the end of the day, I'm grateful to have access to this medication, but it's definitely, and why we're here, it's a love-hate relationship for sure, absolutely. But all in all, I look forward to hopefully not being on them one day, but I am heartened and excited about where technology and science is going, and the fact that at the end of the day, those of us that need to use these steroids will be able to do so in even safer ways and get a higher quality of life. So there's my 2 cents. In honor of the time, I'll wrap it up right there. Thank you so much.
Sharde, thank you so much. I always appreciate how authentic you are. And I have to ask you, because, one of the things I love about you is you really have such a great attitude, and you do your best to make the best of situations happening around you. But when those days are tough, when you've got those cons going on with either the steroids or just where you're at in your journey, what kinds of things help you cope?
Well, for me, it's predominantly my faith. I think, oddly enough, the fact that I've been through so much, as you said, what I hold on to is the fact that I've been through it. It happened, but I made it out. And so I have faith that when those valleys come, there's a light at the end of the tunnel. There's a reason. I'm here and I'm able to give my experience and hopefully uplift some people. But also for those of us, respectfully, who might not be spiritual or, lean on faith, another coping mechanism for me is definitely family and friends and therapy, people that I trust, whom I can feel comfortable confiding in, and having my feelings validated. I don't always have wonderful, peachy things to say. Sometimes I just need to fuss and be in, just kind of sit in that down moment. And thankfully, I'm blessed to have people that I can speak to, whom I trust, that I can be completely honest with about my feelings and not have to feel like I have to always be glass half full, So I think it requires a healthy support system and the balance and self-awareness of being able to say, this is where I am right now, and I don't have to ignore the fact that I don't like it. However, I know that this isn't where I'm going to stay, and that's what helps me a lot.
I really appreciate that honesty. I know there are going to be bad days, and it's so great to be able to have people you can be real with, but also getting to a place, too, where we can try to keep fighting. I know myself, I had a immune issue with my lungs. I did not have a bone marrow transplant, but I was on steroids for about 15 years, and my bones are affected as well. And I am just so thankful that I was breathing through those 15 years, despite the fact that my bones are not the prettiest on film today. And so I am thankful for every breath I got from them. But anyway, on that note, Todd, I understand that you are going to help us explain how our callers can ask some questions.
Yes, if you would like to ask a question, please signal by pressing *1 on your telephone keypad. If you are using a speakerphone, please make sure your mute function is turned off to allow your signal to reach our equipment. A voice prompt on the phone line will indicate when your line is open. Please state your name before posing your question. Again, press *1 to ask a question. We'll pause for just a moment to allow everyone an opportunity to signal for questions.
And while we take that pause, Todd, I'm going to ask one pre-submitted question first, and this is for Dr. Ueda Oshima. Is it better to come off steroids more quickly and potentially risk more GVHD flares, or stick with the steroids as long as possible until you are confident you have GVHD burnout?
Yeah, thanks, Jennifer. I think this is a really great question. I think we're always asking that question. Unfortunately, it hasn't really been looked at and systematically for treatment of chronic GVHD. But I would say that in general, we go slowly over time and carefully over time at tapering steroids because decreasing the dose too quickly will likely result in more flares and more steroid use over time. And we know that it takes time to develop tolerance in chronic GVHD. So the usual recommendation and the usual course of action is to go slow and steady with the steroid taper. And that being said, the approach is really individualized. So I think for certain cases, we sometimes may consider a faster taper than we usually would do if someone has, we know that they have excess toxicity already from steroids or other complications. So I think it's, usually it's better to do a very slow taper and carefully over time, but in certain circumstances, a faster taper may be considered once we weigh the risks and benefits for each particular case. Great question.
Oh, thank you. And actually, I'll ask you just one more really quick before we get to the other one. One person wrote, I have severe AVN from high-dose steroids. What impact does using topical cream steroids or mouthwashes with steroids have on AVN?
Mm-hmm. Yeah, that's another great question. I think the short answer is basically there's very little or very minimal effect from these topical steroids on bone complications or other systemic side effects from steroids. That being said, I think if you use for instance, a large amount of steroid cream on a large surface area of your body, that there are there will be some absorption into the bloodstream, so you do have to be careful. But in general, these mouthwashes, steroid creams, inhaled steroids, I think they're really useful for controlling symptoms. So I would advise that you use it for the amount required for symptom relief and not worry about the systemic absorption of these steroids.
Thank you so much. Okay, Todd, do we have anyone on the line?
Yes, we do. We'll take our first question here. Caller, please go ahead.
Hi there. My name is Kathy, and I have a few questions, but I'll just do them one at a time. I was wondering, Doctor, whether what you would recommend or what treatments are available for steroid-induced myopathy.
Yeah, that is a terrific question, and I think that's a big challenge in the field. There is really no magic cure or magic pill to reduce that effect on the bone on the muscles, but I think that what you can do is to try to have as much exercise and strength training as possible while you're on the steroids. So I think if you're able to get a physical therapist or a trainer, I think that's one route that you can take. But unfortunately, there's not a lot of medication-wise that we can do to prevent that myopathy. But I think strength training and preventative exercise is the key.
Thank you.
Thank you. We'll take our next question. Sorry, caller, please go ahead.
My name is George. My wife carries a multiple myeloma on pancreas, and she collecting the stem cells. She have a combination chemotherapy, RVT, for 2 years, and acupuncture, RVT, and she is in remission. And she have a 5-year maintenance chemotherapy. 2 years ago, she started treatment. When is the best time to have, the bone marrow transplant? After, 10 years, still in remission. Can you have any suggestion?
Yeah, I guess, so you're asking when is the best time to get a transplant for myeloma. I think in general we recommend transplant at the first good response to induction treatment for myeloma, but it sounds like your wife had a pretty unique case, so I can't say in particular about her case what I would suggest, but it is a good thing that she has stored stem cells already.
Okay, thank you.
Thank you. We do have some more questions in queue. We'll take our next question. Caller, please go ahead.
Yes, hi, my name is Jody. I had an allogenic stem cell transplant in February of 17, chronic GVHD. I just started literally this week my third round of steroids, so I'm on 40 milligrams. I was hesitant, that love-hate relationship with steroids, to go on them quickly, so we tried sirolimus for a little bit. So my question related mostly to steroids. Thank you, Dr. Oshima, for talking and addressing the, getting the strength training and the cardio training recommendations. As the physical challenges, and the concerns for future, I think my mental challenge is mostly that the whole weight gain process. I think the last time I went off steroids, it took me about a year to get the extra weight off. Do you have any dietary suggestions along with your strength training and cardio suggestions? I've been focused on whole food nutrition for a little over a year already, which was how I got the weight off from the last round. So I was wondering if there was something that you guys have found and recommend to patients.
Mm-hmm. Yeah, another great question. I think weight gain is one of the, as Sharde alluded to also, such a difficult side effect to deal with, especially after several courses of, higher steroid doses. I think in general we recommend, low fat, low sugar diet, low cholesterol diet to help with the weight gain. And I think, as you mentioned, trying to avoid processed foods, so sticking to whole foods and, as natural as you can with your diet is always helpful. Another thing that we do often is refer patients to specialized dietitians or nutritionists who are skilled in counseling post-transplant patients. So that might be something to inquire with your transplant doctor about. So I think in addition to exercise, I think diet is really an important aspect of it. And there are a lot of things that you could try to help with that. But I think it's really difficult, and I think it's always helpful to have a coach or, some nutritionist that you trust and have a good relationship to help you on that journey.
Thank you. We have a couple more questions in queue. Again, to ask a question, please press star 1. We'll take our next question. Caller, please go ahead.
My name's Chris. I had a allogenic transplant in 2014 and did various amounts of prednisone through the years up until the end of 17. I voluntarily went off of it, just not liking the effects. So I've been 3.5 years without doing it, and I want to know how long is the effects of the toxicity of a steroid effective in your body?
Yeah. So in general, we think that the side effects go away with time after several weeks of being off the medication or after being on a really low dose. But as you mentioned, I think some of the downstream consequences of steroids, if you have things like cataract disease or fractures or effects on the bones, some of those side effects are, difficult to reverse. So I think there are, longer-standing side effects from steroids that, may not get better very quickly. But a lot of the other things like the weight gain, the fat redistribution, the effects on your immune system and infection risk, that does get better the more time that you have away from steroids.
Thank you. We'll take our next question. Caller, please go ahead.
Hi, it's Kathy again. I was wondering with regards to steroid tapering, once somebody has been down to 10 milligrams and have been on it for a long time, such as myself, I've been on it for about 1.5 years, and prior had been at 80 milligrams of tapering down over about a year to the 10 milligrams. What is your preferred tapering choices from 10 milligrams to 0?
Mm-hmm. Yeah, and I think this is one area that's very highly variable amongst different physicians and providers. But usually at a low dose, such as 10 milligrams, we would do something like either, decreasing by 1 milligram a month, or sometimes like 2.5 milligrams a month, and do it very slowly. And when we do that, sometimes we'll see manifestations of the adrenal insufficiency, which is when you've been on steroids for so long, your normal adrenal glands that produce your normal doses of steroids that the body needs is sluggish. So you may feel fatigue or other, GI symptoms that may be attributed to the adrenal insufficiency. So your doctor can do a test to see if your adrenal glands are working well enough or not, and if not, it may be useful to convert the prednisone to hydrocortisone, which is another type of steroid that works more like the steroids that are secreted by the adrenal glands. So sometimes once you're on a low dose of prednisone, we'll switch the type of steroids to this adrenal replacement dose. So that may be something to consider. But as you said, once you're on a low dose of steroids, the taper is usually very, very prolonged and done little by little. And sometimes we do see even flares come up even if we're tapering such small doses. So we still have to do it carefully.
Mm-hmm. With the hydrocortisone, at what dose of prednisone would you usually switch to hydrocortisone if there's a high suspicion of adrenal insufficiency?
Yeah, usually around this time, so 5 to 10 milligrams is around the range where we start to get to a level that's in, the adrenal dose, so to speak. So it's time to start considering it, yeah.
Right. And the hydrocortisone, does it have the same side effects as prednisone?
If it's taken at a high dose, it can, but in general, it's a really short-acting type of steroid, so it doesn't have a prolonged effect like prednisone. So in theory, it's better to be on the short-acting, the hydrocortisone, and it's given, in more frequent dosings, usually 2 or 3 times a day.
Right. And then if you are on prednisone, and even if you're tapering, if you're on it, how do you diagnose adrenal insufficiency if you've got prednisone on board?
Mm-hmm. We would usually do the stimulation test, so where they it's a specialized time test where you give a drug called ACTH and then measure the cortisol level in the blood at specific points. And we would usually, try to do it on a day that you're not on prednisone, if you're on the alternate day dosing, or hold the dose until you can do the test for that day.
Right. What is the half-life of prednisone? How long does it stay in your body at one dose?
Yeah, I don't know the exact half-life in hours, but because it's a daily dosed medication, I would guess it's 12 to 24 hours. Yeah.
Right. Okay, thank you. Really appreciate it.
Yeah. You're welcome.
I'm going to step in for a moment now and try to get a couple more of our pre-submitted questions in. First of all, one person writes, is there anything you can do to get rid of that moon face from prednisone?
Yeah, I think I wish there was a magic cure for that, but I think with time it will improve as we've been discussing. I think it's a very common side effect of steroids, and I think it's predicted to happen in about 60 to 70% of patients who are on steroids long term, so it's quite common. And even at a dose as low as 10 to 20 milligrams, people can get the cushingoid moon face side effects. But once you're on a lower dose or have stopped the therapy altogether, it will improve with time.
Great, thank you. And then, is a short course of steroids useful for a GVHD flare? And how about low-dose steroids for a flare?
Mm-hmm. Yeah, I think in general, short course of steroids is not useful or usually done, and that's because we worry about reflare of the process if we remove the steroids too quickly. And in terms of lower dose steroids, I think sometimes we do, after we consider a specific case or a specific patient's case, sometimes we try to use lower doses. So if we know, for instance, that somebody had a good response at a third of a milligram per kilogram, we may try to use a more lower dose for if somebody has a recurrent flare. So I would say that the treatment is individualized, and the guiding principle, again, is to try to use the lowest dose possible.
Okay, thank you. And this last one I'll give you today is, are you aware of any new options that are coming out to treat chronic lung GVHD in adolescents?
Mm-hmm. Yeah, I think lung GVHD is one of the more challenging parts of managing chronic GVHD. In terms of clinical trials, I know that Jakafi is being investigated in a clinical trial for BOS, which is chronic lung GVHD. And also, I know there's a trial looking at the cousin drug to Jakafi, idasitinib, for BOS as well. And as I mentioned, the new drug, Rezurock, also showed some partial improvement in patients with lung GVHD. So I think those are potential options, and hopefully there will be others explored in upcoming clinical trials.
That is good to hear. And also, there's one here I know we do not have time to fully address today on coping with scleroderma GVHD, but I want to let our callers know our Season 6 podcast just came out, and I know that we have some additional great resources on GVHD there, and we're just going to continue to keep bringing you more as well. But a huge thank you to the doctor and Sharde, and of course everyone for joining us here. We will be sending out that survey, so if you can help us out with some great future topics or feedback, we'd greatly appreciate it. Or if there's anything we can do to support you, you are welcome to reach out at 1-800-LINK-BMT. Again, thank you to everyone, and we hope we see you next month. We're going to have a wonderful speaker, Shirley Otis Green, who will be joining us and talking about dealing with all the emotions with this journey. Some examples might be survivor's guilt. Some might be when people feel like everyone expects them to be really positive on those tough days. And so just tackling some of those emotions, that will be our Lunch and Learn next month. So we hope you will join us then. But until then, you have yourself a great day, and thank you for tuning in.